Yes, let's get started.
Oh, this light's, it's pretty bright up here. How are y'all doing? Okay, it's time to rock and roll and have a great session this afternoon. So for those of you who don't know me, I'm Kyle Yasuda. I'm from Seattle, Washington. And I'd love to welcome you to the 16th annual Peds for the 21st Century Symposium. Peds 21 program was established to prepare pediatricians to face key issues that affect pediatric care. This year, we turn our attention to the opioid crisis, the need to balance the prevention of opioid misuse, opioid use disorder, and overdose with the continued need for appropriate pain management. I think those are topics we all could benefit from. The opioid crisis, I'm just going to say a few words, then we'll start. The opioid crisis reaches across all age, socioeconomic, and ethnic divides. No matter where you work, chances are you touch the lives of families or patients who are struggling with an issue related to opioid addiction. To make sure you can best help your patients and communities, the AP section on anesthesiology and pain management has worked with the committees on drugs and substance use and prevention, the Council of Injury, Violence, and Poison Prevention, and the sections of integrated medicine and neonatal perinatal medicine to put together an enlightening afternoon. It's an incredible collaboration to put this event on, so it's really good. So a big thanks to them, number one, as well as our Peds 21 Planning Chair, Dr. Rita Agarwal. Let's go, big hand, come on. Also, Peds 21 is supported in part by the Conrad Hilton Foundation. So I'd like to thank our friends at the Conrad Hilton Foundation as well. One more hand. Since the opioid crisis affects pediatric patients of all ages, today's symposium will cover neonatal abstinence syndrome, unintentional poisoning of young children, as well as how to recognize adolescent, teen, and young adults who may be at risk, and either treat them or refer them for treatment. We acknowledge that evidence-based use of opioids for pain management does have a place in medicine. So the final 3 sessions will discuss appropriate pain management. My knees are really bugging me right now, walking all the way down. Oh, excuse me, wrong script here. Sorry, Rita. It's okay. The goal being to increase an understanding of pain and the importance of treatment, as well as how to minimize unsafe use of opioids. For those of you who haven't seen the poster session, you need to check it out. 50 posters are on display throughout the duration of the Peds 21 program. Be sure to take a look at during the 3 p.m. break. Now I'd like to introduce our Peds 21 Planning Chair. She's just awesome. A few people are experts on the subject of pain, pediatric acute pain, and anesthesia is Dr. Rita Agarwal, a clinical professor, pediatric anesthesiologist, pain medicine provider at Stanford Lucile Packard Children's Hospital. She also serves as the president of the Society for Pediatric Pain Medicine. Previously, she was the pediatric anesthesia program director at the University of Colorado for 18 years, course director for the Colorado Review of Anesthesiology for surgery centers and hospitals for 17 years. Dr. Agarwal is on the board of the Society for Pediatric Anesthesia and is vice president for the Society of Pediatric Pain Management. You've got too many accolades, Rita. And immediate past chair of the American Academy of Pediatrics Section of Anesthesia and Pain Management. It's my honor to introduce Dr. Rita Agarwal.
Thank you so much for that incredibly kind introduction. I know there are a lot of people who are more expert than I am on the management of pediatric pain management, and many of them are on this panel. I think we have an amazing group of people lined up on an amazing variety of topics, so I hope you all find something that is useful to take from this. I just want to talk a little bit about how this meeting is set up. We're going to have 3 20-minute sessions first, followed by a Q&A session, followed by a 30-minute break so that you can peruse more of the posters. There's some really incredible posters out there on a wide variety of different topics. Evaluations for the session can be found on the AAP Experience app and I'm sure online as well. Peds 21 was proposed in the light of the opioid crisis and the continued need for appropriate pain management. We were really interested in understanding the havoc that misuse of opioids has wreaked on pediatric patients and who were at the time being largely ignored by both the media and scientific circles. We wanted to provide practical advice on preventing and recognizing the misuse of opioids. And while addiction and opioid use disorder are huge problems for patients and their families and for society as a whole, inadequate and inappropriate pain management are still also ongoing concerns and cannot be disregarded. There are many techniques that can help with pain management, including things like deep breathing, relaxation, distraction, integrative medicine, multimodal approaches to pain. Our goal is to help increase understanding of pain, emphasizing the importance of its treatment while educating everyone on limiting exposure and minimizing unsafe use of opioids, discussing proper storage and disposal of controlled substances, and hopefully giving you some advice on how to recognize if opioid misuse is occurring and who and how you can possibly treat that. We're talking about children across all ages, and we know that children can get exposed in utero all the way up into adolescence and young adulthood. This is going to be a great session. I've seen all of the slides, so I know how amazing this information is going to be. I want to talk for 1 second about how to ask questions. Basically, the instructions are on this slide, but you go to the website that's listed there, peds.cnf.io. You mark which session this is, it's Peds 21, and then you can write in your question. It'll come to me as the moderator, and for those of you who are logged in, you'll also get to see which questions have been asked, and you can actually vote for your favorite. So if it's a similar question to what you were thinking of asking, you can hit that, and then I, as the moderator, will try and facilitate that Q&A session. So with that, let's go ahead and start our panel with a discussion on the youngest of our pediatric patients who may be affected by opioid exposure. It is my great pleasure to invite Dr. Matthew Grossman to give his presentation on neonatal abstinence syndrome and infants exposed in utero. Dr. Grossman is an associate professor of pediatrics, vice chair for quality, and a quality and safety officer at Yale New Haven. Thank you.
All right, thanks for having me. Let's get started. Okay, so we're going to start with the baby part of this. So lots of people have opioid use disorder, not a surprise for everybody here. And that number has been growing, and some of the people who have that are women, and some of those women get pregnant. About 1 to 2% of all pregnancies in the United States are of women who are using opioids. The way that tends to be managed in pregnancy is with medication-assisted treatment, among other things. It's pretty rare to have a pregnant woman weaned off of their opioids during pregnancy, so we see a lot of babies exposed particularly to methadone and buprenorphine, but also for those who elude some prenatal care or otherwise, we do see other opioids as well. There has been at minimum a 5-fold increase in seeing babies with opioid withdrawal in the last decade, and it's probably quite a bit more than that. So there's lots more of these babies. This is a 2015 paper looked at how many NICU beds were being filled with babies with NAS, and it was about 4% at that time. In some hospitals, as much as 50%. And this is babies who have neonatal abstinence syndrome spend a lot of time in the hospital. Outside of prematurity, this is one of, if not the longest lengths of stay of anything in pediatrics, is about 3 weeks. And so what happens to the baby? So babies in utero, if the mom is receiving methadone or buprenorphine, are seeing opioids pretty consistently. And so most of the action seems to be in the locus coeruleus, and there's an upregulation of receptors, particularly with norepinephrine, to keep a level of homeostasis. And once they're born, they stop getting the opioid, and there's this surge of norepinephrine release, which seems to coincide with a lot of withdrawal signs. And withdrawal that we see is pretty similar to what we see in adults, just in a smaller form. And historically, this is not a new disorder. This is described in the medical literature in the 1800s. And really going through the 1950s, a lot of literature really talks about the high mortality rate of this. And so the treatment, there wasn't much of a treatment during that time. In the 1960s, when methadone treatment came into play, and in the 70s is really where the modern era of treating neonatal abstinence syndrome came in with the work of Loretta Finnegan in Philadelphia. There was a heroin epidemic in Philadelphia in the mid-70s, and Dr. Finnegan and her colleagues were inundated with these babies, and they were looking for a way to kind of standardize their approach. And for those of you who have ever taken care of one of these babies, this should look familiar. This is a version of the modified Finnegan tool. It has 29 items. It's a really great cataloging of the signs of withdrawal that a baby may exhibit, and split into different categories like vasomotor and neurological and gastrointestinal. And the way it works, if you haven't done it, has anyone not seen this before? Right, okay, good. So each withdrawal sign is given a point total. The ones that seem a little bit worse are given higher. So if you have severe tremors, you get 3 points, and if you're yawning a little too much, you get 1 point. And then what you do is you add up the scores, and usually do it somewhere between 2, 4, 6 hours, somewhere in that range. You add them up. If you get 3 scores of 8 in a row, that indicates a need for the start of medication. So this is where the standard approach was built out of, and there's some variation in how this is managed around the country, but there's 5 major approaches. One is medications are the key to treatment. There's been a lot of study trying to figure out the right medication or the right combination of medications to use, but really that's the key, and again, the Finnegan guides that. Where these babies are managed, again, it's mostly in NICUs. There is some variation. You'll see some management on inpatient units, some in newborn nurseries, and some even in outpatient, and often a combination of all of those, but NICU is kind of the mainstay of it. And then Finnegan scores, of course, everything is guided by the Finnegan scores. There have been lots of attempts to make simpler versions of it that have gotten the same results, but nobody uses them. It's really Finnegan or slight variations of that. Again, medication is the key, and the way it's usually dosed is once you start the medication, you go down very slowly, usually by about 10% each day that you have a good day. So in other words, it ends up being, that's sort of what leads to the long lengths of stay is once you start medication, usually on it for weeks often. And then like in any NICU situation, it's really the staff or traditional NICU situation, the staff is caring for the baby. NICU nurses really own these babies. I still remember the one time where I examined a NICU baby without asking permission, which is a one-time mistake, if anyone's made that one. And so it's one of the real values of the NICU is how much ownership the nurses take of them, but often it leaves the family out. So there has been efforts with this increase in the stress on the healthcare system, particularly in pockets where this is a really more of an epidemic than in other areas. It's been an effort to figure out how to do this a little bit better. And Stephen Patrick, who's really the leading researcher in this field, led a Vermont-Oxford network study with 199 institutions to try to improve the care of these kids and actually reduce the length of stay across the network from 21 days to 19 days. So a 2-day reduction in length of stay over 190 institutions is really significant. And then Ohio, which really nobody does quality improvement better than the folks in Ohio, their first project, they reduced length of stay from 36 days for these babies down to 18 days. And then more recently in a collaborative throughout the state, they've got the length of stay down to somewhere between 14 and 15 days. So we took a little bit of a different approach at Yale, which I'm going to share with you a little bit. And what we really did is looked at these 5 tenets of care and looked at where they came from and why we were doing them. And we found some interesting things. We first really started looking at medications. And the way we looked at it, I know we just started, but we can do a little game first just to get everybody loose. So there's 9 dots up there. What I want you to do is connect all 9 of these dots with 4 lines without taking your pen off the imaginary paper. I'm gonna give you about 30 seconds. If you know how to do it, you can just look smug. It's fine.
You can-
Yeah, like that, yeah. Brain teaser for the day. All right, everybody got it? Okay, so to do this, you have to go outside the box. And so this is actually where this saying comes from, is thinking outside the box. Usually when we think about that saying, I always think that when people are deciding whether it's 5 or 6 and you actually think about it being purple, that it's something just completely off of what we're doing, but it's not actually what it comes from. The idea, if you look, there actually isn't a box here. And so what happens in our minds is we created a box. That was why this is so difficult, because we create this box, and to go outside the box feels like we're breaking a rule. But that isn't a rule, it's a rule that we make in our head. And so thinking outside the box is realizing that it isn't actually a box, and that some of these rules are not real rules. They're just things that we made up. And so that was sort of the approach we took when looking at what we were doing. So with medications, if you go and look at the studies over the years with medications and length of stay, you can find a length of stay for kids treated with morphine that ranges from 8 days to 34 days at different institutions. And with tincture of opium, which was used frequently until the last 10 years or so, 17 days to 79 days. And again, these are kids with similar exposures, similar protocols for treatment, and they were just born, so they don't have much of a past medical history. So this is really bizarre, and you don't see this in other disorders. And so when we looked at this, we didn't have an explanation for this, but the best we could come up with is that maybe it really wasn't about the medications, even though that's really where the push had been. So when we looked at that, and when we looked at this and we looked at all of them, why we were doing it this way, what we found is the reason we were managing kids the way we were doing it today is because that's what we were doing it yesterday. And that was really it. There wasn't a lot of evidence to support what we were doing. So the first line treatment in everybody's protocol for neonatal abstinence syndrome is non-pharmacologic care, which means holding the baby, swaddling them. The AAP guidelines say that, but they only spend about 50 words on it, and they spend about 1,600 words on the medication. It doesn't feel like, if you're a neonatologist and you're putting kids on ECMO, this doesn't seem like much of a treatment, I don't think, but it's listed for everybody. And so we started to look into this and said, and I'm not a neonatologist, I'm actually a hospitalist, so we were able to really look at this a little, we had a better setting to do that. We looked into literature, and there's a paper by Abraham and his group up in Vancouver where they did this really odd thing, is they took the baby and they took the mom and they put them together. And it was one of those ideas that was just crazy enough to work, and it turns out the outcomes were better for both the babies and the moms. And so we thought, hey, maybe there's something to this, and we started to really focus on that as a first-line treatment and saw really dramatic results. And so when we thought about that, we thought, boy, if this were the results we saw, if it were a medication, everybody would be doing it. And so we said, well, why don't we just think about it that way? We'll think about it like asthma. And so mom is the albuterol. And so when you have that mindset where the mom is actually a medicine, it has to change how you do things. Because we were managing these kids in a NICU, and we started to ask why we were doing it in the NICU, and we had no great answer other than that's where they always were. They don't need lines, they don't need respiratory support, there's nothing that actually about intensive care that these kids need. And this is what our NICU looked like at the time. We have a much nicer one now, and it's about the least friendly place for a family. There's like that one chair with the tape on it, and that's about it. So this was not an area where you could do much of this non-pharmacologic care. You could swaddle the babies, but you were feeding them on a 3-hour schedule. Has anyone had a baby before? Did you feed them? Did you ever say that they weren't due to eat? Has anyone heard that before for an NAS baby? Yeah, they're not due to eat because they're due every 3 hours. That's when they eat. That is not how babies work, and particularly sort of cranky babies. So and we thought about it from the albuterol idea. So if you had an asthmatic and you had a unit that didn't carry albuterol, which essentially is what our NICU didn't carry mom, so it didn't carry albuterol, and you had one unit that did, where would you send the asthmatic? To the albuterol unit or the non? It's a pretty silly question, but that's what we were doing with NAS. So we kept him in the inpatient unit, and there were really things that the parents, and I say mom, but it's dad, it's a whole family, it takes a village with this, they could hold the baby all the time. They could feed the kid whenever the kid was hungry, and that could be every 45 minutes. And as soon as withdrawal started, they could intervene right away. And these were things that we just couldn't do with our staffing. It's just not possible. You can't be there all the time. So we said, okay, mom and baby need to be together. Then we started to look at the Finnegan scores. And so this is sort of what was set up as the law. This was the box. You had to use the Finnegan scores, and you had to use a score of 8. And I'm sure all of you use scores of 8. Does anyone know why you use scores of 8? This is why. It's a paragraph from the 1975 paper. The infant with a score of 7 or less was not treated with drugs for abstinence syndrome because in our experience, he would recover rapidly with swaddling and demand feedings. Infants whose scores 8 or above were treated pharmacologically. It's never been studied. This is just from the 1975 paper. This is just what they decided to try, and that's what we have run with as the law since then. And so it is not based on anything other than that. So there are some problems with the Finnegan score, and those of you who have done it probably are aware of these. So if you look at the short-term outcomes of this, it provides the longest length of stay for any disease in pediatrics and lots of medications of questionable safety. The whole purpose of the treatment is just to get below that threshold score. So if you sneezed 4 times, that's of course no good, but if you sneeze 3 times, then everything's fine, because that's one of the things on there, and you can see that in withdrawal. You have to actually disturb the infant to do a successful Finnegan score. A couple of the items on there are a hyperactive Moro reflex and tremors when disturbed. So in order to do a proper score, you have to take a calm baby, unwrap them, and see if you can get them to withdraw. So it can actually be doing some harm. It can also be slow to respond. You have to get 3 scores of 8. That could take as long as 10 hours. You could have a baby who's been miserable and screaming for 10 hours before you would respond because you didn't have 3 scores of 8 before that. And it can be really powerful and harmful meds to give to treat what could be an extra sneeze or a yawn. So we thought, gosh, we don't really care. We know that these are signs of withdrawal, but we don't really care that much about sneezing and yawning. And we also noticed that pretty much all of our babies who were exposed to methadone and almost all of the other ones were showing signs of withdrawal. So they were all experiencing NAS and going through this experience. So we're really trying to get them to have fewer sneezes or yawns? We didn't care about those, so what did we care about? And we thought we wanted them to be babies, to do things that babies are able to do, which is a pretty limited job description. They're supposed to be able to eat and sleep, and you should be able to calm them down. So those are the things that we looked at. Can you eat, can you sleep, and can you be consoled? When we actually looked at this in our institution, it took a while because of administrative things. We had to keep getting the Finnegan scores. We looked at 50 kids that we started treating using this eat, sleep, console approach, and only 6 out of the 50 received morphine. And if we had used Finnegan, because we were still getting those in the background, actually 31 or 62% of them would have gotten morphine. And they all had good outcomes. They went home, no readmissions, no problems in follow-up. So moving on, we had medication dosing, another key. We had to go through these. Once you started morphine, the thing that happens when you start morphine, you don't give a dose of morphine. You start this whole weaning process. So 1 dose of morphine is actually 100 doses of morphine. You have to stabilize it. You're giving 8 doses a day, and you have to go down very slowly. So why were we doing it that way? What was the importance of just going down once a day? There is just no evidence for this. This is what's often done in the adult world. It's never been studied here. And so we started giving it to babies as they needed it. And some of them needed a lot of it, but a lot of kids just had a couple of episodes where they were irritable, and 1 dose of morphine would take care of it. So we did that at Yale, and that's been replicated in North Carolina and Boston with a lot of success, where often it's really 1 or 2 doses of medication rather than the 100 that the baby will need. And then the staff cares for the baby part of this. So these tend to be vulnerable families, vulnerable populations, and what we're doing often is a good job of caring for the baby and then handing them off at the end to a mom who is not bonded with the baby. There's a great study a qualitative study from San Antonio where they interviewed moms, and the moms feel guilty, they feel judged by the staff, they feel that no one understands what they're going through, and they know they've done what they have done, whether even if it's prescribed, has caused their baby to go through this, and they have a terrible experience often with the staff. So we're taking these vulnerable populations, we're separating them from their babies and their moms. Let me say that again, we're separating babies and moms when we don't need to, and then we are kind of handing them off at the end. and where they haven't bonded, and you still have a baby who's going to be going through some withdrawal signs. And so this does not seem like a good idea, and that was sort of where we came from. We said, what we need to do is we know the importance of maternal-infant bonding, but for some reason we're not doing it here, where it may be the most important. And so that was really a focus for us. Our job became not to take care of the baby, but to support the family. So the whole approach for this was a focus on non-pharmacologic care as a real treatment for this disorder. That this swaddling, this holding, this feeding the babies on demand was a real treatment with powerful results. Where we started to care for these kids was wherever the mom and baby could be together. If you only had a NICU, then you had to figure out how to have the mom and baby be able to room in together there, which a lot of our institutions in Connecticut have figured out how to do. Or it can be in a NICU, it can be anywhere as long as mom and baby are together. And because mom is the medication. Again, you wouldn't send a kid with asthma to a unit that didn't have albuterol, and you shouldn't be sending a baby going through withdrawal without their mom. Using these eat, sleep, console assessments are much easier, they're simpler, they're what we care about. You don't have to disturb the patient. You actually have to ask how the baby's doing instead of what the score is. You aren't focused on the individual withdrawal signs as much as how the baby is doing overall. Giving medications as needed can greatly reduce the amount of medication these babies need. This approach is not anti-medication at all. There is a great need for medication for a lot of these babies, but often not nearly as much as we're giving. And the whole idea is to support the family. We want this to go well in the hospital and beyond. We want to encourage bonding. We want to set up support systems as they go home. And that is the idea. It's not to care for the baby and then hand them off and hope for the best. So our results at Yale, we started with this is a busy slide. Each one of those dots is an individual patient. The blue line is our average length of stay. We started at about 23 days, and we did all these interventions sort of that I listed below, and over the last 5 years, our average length of stay is around 6 days. It wasn't really our goal to reduce the length of stay. As I said, we wanted this to go better for babies in the hospital and at home. We used to have the experience that after about 3 or 4 weeks, we would tell the family they were ready to go, and they would say, well, we don't even have a crib yet. We're not ready to go home yet. Can we have another couple of days? Whereas now, with encouraging the bonding, we have the baby and mom. The mom is holding the baby at the door saying, hey, can we go home after about 5 days? And the answer is yes at that point. And these results have been replicated at several other institutions. So simply put, the approach is really that mom is medicine, and we have to think of that mindset. Again, it's not where we must do it on the floor or in the NICU. Mom is the medicine. Mom and baby need to be together. This has to be beyond encouraged. This can't be something where we allow rooming in or encourage rooming in. It has to be something that's done prenatally, where we get them to, and understand that this is the treatment for the baby. How can somebody be here all the time? We have to treat the baby like a baby. If you have a crying baby, the approach to that is not to stand over them and calculate the dose of morphine. It's to pick the baby up and treat them like a baby first. Oftentimes, that's all we need to do. If anyone's ever seen a news story about a baby with NAS, there's always the doctor standing over the crying baby that no one's holding. So just pretend it's a baby. Do what you do for a baby, and treat the mom with the same respect you would treat any other mom. And it's really as simple as that, and it can make a big difference. But the idea is making sure, if you're thinking about this at your institutions, is looking for where there are boxes where there are really just dots. Thank you, everybody.
Thank you for staying on time. That was awesome.